we were told.
You go in Maryland. You go east of Maryland too.
Yes.
Where do you go? What town?
Choptank Road.
Call the meeting of the Health Professions Subcommittee to order here. Clerk, could you call the roll?
Senator Saslaw,
Senator Saslaw.
Here.
Senator Newman, Senator Edwards, Senator Lewis,
Here.
Senator Junavant,
Here.
Senator Suderline, Senator Pillion,
Here.
Senator Barker.
Here.
Mr. Chair, we have a quorum.
All right, we have a quorum. It took a little while, but we got here. So, and there are at least one or maybe a couple others who will may drift in a little bit later. So anyway, we have only one bill that's up here today, and that's Senate Bill 375, patroned by Senator Peterson. What we're going to do today is have Senator Peterson present the bill, and then we're going to have 20 minutes of testimony from each of the two sides, and then we will move on to action on what disposition we'll make with the bill in terms of recommendations to the full committee. All right, Senator Peterson.
Thank you, Mr. Chair, members of the subcommittee. This is Senate Bill 375, and at the risk of stating the obvious, it deals with the practice of optometry and specifically the scope of practice. There are some different sections to the bill, so I think it's easiest to kind of categorize what sections there are, what is actually a new and substantive change, and some of it is just sort of moving things around in the code. So if you start with the bill, it takes the existing definition of optometry, which is lines 39 through 55, and basically strikes all that and just restates it that it will be defined in 54.1-3201. Then if you carry forward to page 2, you get to the new code section, which is 54.1-3201, where we define what constitutes the practice of optometry. And what we've done in this bill is we've said what it is and what it isn't, which is, I think, unique in the code, but I'll let the experts testify to that. But in the first few paragraphs, starting with line 74, you can see the practice of optometry includes basically vision care, eye examination, recognizing, diagnosing, and solving problems involving vision, and carrying forward using pre- and post-op care, use of diagnostics, things of that. And all that is through 75 through 88, and that's existing law. I don't think there's anything there that's controversial or not accepted by pretty much everybody. Then starting in line 89, we say except as provided in 54.1-3222 and 3225, the practice of optometry does not include. So here's where we're stating that the practice of optometry, which is basically providing for people's vision, does not include, and then we have a whole list of non-covered items, so items that would be outside of the scope of practice, including retinal laser procedures, penetrating keratoplasty, corneal transplants, and then a whole list of surgeries, incisional or excisional surgeries, cryotherapy, iodizing radiation, the use of injections, administration of or surgery using general anesthesia, and then you can see the catch-all is other invasive modalities. And that's been generally, and I speak as an absolute layperson, okay? I think I got through about 12th grade science, and that's about where I tapped out. But the idea is invasive modalities generally are not included in the scope of practice. Now, if we get down to Article 6, which is line 117, here is where we will permit laser surgery to be performed by optometrists, and this is the meat of the bill. So this is where the pushback is going to occur. And basically it says that the board shall certify an optometrist to perform laser surgery, and then it talks about peripheral iridotomy, selective laser trabeculoplasty, and YAG capsulotomy. And I'm going to let the experts sort of define those three categories: the iridotomy, trabeculoplasty, and the YAG capsulotomy. I have had them explain to me. I'm not in a position to re-explain it to you, but basically, as I understand, these are surgical procedures that are simpler and within the knowledge base of optometrists. Now, I have talked to ophthalmologists in my community that do not agree, and that's why we're going to have to make a decision on this. But what I do understand is that these three defined procedures basically do not, I would say, creep overly excessively into the practice of ophthalmology, which I understand obviously is a medical profession, and this is not. But that's kind of where we are, Mr. Chair. That's about the best I can do without turning it over to the experts.
All right, thank you, Senator Peterson. Are there any questions of the patron or comments from members of the committee?
Okay, and I have people here.
All right, what we will do is take 20 minutes first for those who are supporting the bill, and then take up to 20 minutes of testimony from those who are in opposition to the bill. So I have my watch here, and we will take care of it. So you certainly can.
You want me near the mic?
Yeah, let me pass this over to you.
Good morning. My name is Dr. Jeff Michaels. I'm a doctor of optometry in Virginia for the past 23 years. I'm a past president of the Virginia Optometric Association and past Virginia Optometrist of the Year. Thank you, Mr. Chairman, and this committee for allowing time for this important issue, and thank you, Senator Peterson, for your patronage and your courage. This bill adds 3 very specific in-office eye laser procedures to the scope of optometry. The language of the bill has exclusions to ensure that only these 3 procedures and no surgeries can come of it. These are in-office procedures. They are not operating room procedures. There's no general anesthesia. If you've ever been to a doctor of optometry office in the past, you may recall putting your chin at the microscope to have your eye health evaluated. That microscope is a part of every eye exam that an optometrist performs. These procedures use that same microscope. This bill allows for a continuity of care for our patients that have an existing relationship with doctors of optometry. It helps Virginians get timely access to care without the need for additional travel cost. It benefits the working poor and anybody that has difficulty getting to an appointment. These 3 laser procedures are a part of our education. They are a part of our training, and they are a part of our current patient care. Now, what you're going to hear from the opposition today is that we're not qualified, didn't go to med school, didn't do a surgical residency. Yet these procedures have been performed by doctors of optometry since the 1990s. Over 100,000 procedures without malpractice, without a formal complaint about patient care, not even a formal complaint about patient care from an ophthalmologist in any of these states. The argument that optometrists are not qualified to perform in-office eye laser procedures ended in the 1990s. You're going to hear the opposition say that our training was only over a weekend course. In our doctorate degree program, optometrists train for approximately 10,000 hours. We treat more than 2,000 patients before being independent. We treat glaucoma and cataract care, take 3 national board exams and the certification exam. You cannot fit that into a weekend. Optometrists have been treating conditions in this bill, glaucoma and after cataract care, in Virginia since the 1990s. We've treated every complication that comes from these procedures for more than 25 years because the complications from these procedures are not unique to these procedures. Every published report shows that the complication rate from these 3 procedures is low, but it is not to be taken lightly. And that's why we've treated these complications for more than 25 years. You're also going to hear the opposition say that when an optometrist performs a laser procedure, it requires a retreatment 2.5 times compared to if an ophthalmologist did that laser procedure. That is cited from a 2016 published article by an ophthalmology paid consultant. The study showed that one optometrist in Oklahoma was conservative in his treatment. Ophthalmology wrote a paper about it, and they use it as a headline about retreatment rates. What didn't make that headline was that same published article proved that doctors of optometry are providing effective, efficient, and successful laser care because this in-office procedure was keeping the majority of optometry-treated eyes away from the operating room at a rate much better than ophthalmology-treated eyes. The bill, it's not about retreatment rates. It's not about this one optometrist from Oklahoma. It's about the ability for doctors of optometry to provide care within our scope, education, and training. And the fact that more than 100,000 procedures have been done by doctors of optometry across several states for more than 25 years without ill effect makes that point. These procedures are now standard treatments. You may hear today.
The question is, how many states allow these 3 procedures?
8.
To be 8, okay.
You may hear our opposition say that the Veterans Administration revoked laser privileges for optometrists. That system has now changed. And now the Veterans Administration refers our heroes, veterans, to private practice optometry offices to do these laser procedures. You may also hear them say something about a Vermont study. In 2019, Vermont optometrists were going for scope change. They were asking for these same laser procedures and also in-office eyelid surgery. In our hopes of reducing opposition for this bill, we purposely excluded the in-office eyelid surgery, so there's no scalpels in this legislation. In Vermont, they sent the bill to study, an ophthalmology-led study, and that Vermont study implied that no optometry school was teaching these procedures. I have affidavits from every college of optometry in the country that shows that these procedures are indeed being taught and the students are hands-on. Laser physics, biophysics, applications, indications, contraindications, and much more. The bill also requires a special certification for a doctor of optometry using these lasers. Oversight for that's going to be provided by Optometry's licensing board. Special certification is not required for ophthalmology. A recent study from the University of Washington showed that ophthalmology residents had low confidence and low ability on one of these laser procedures. They started a program that was very similar to our certification program, whereby they started classroom education, hands-on training, and a written exam. The results were it increased the ability and confidence of these MDs to do this laser procedure. That's literally the certification program we have in place. For optometry, that's a refresher course after we have our doctorate degree. For ophthalmology residents at the University of Washington, it's now their training. Now, for the past 40 years, we've advanced our scope of practice as our education and our training have evolved. This is not a light ask. Ophthalmology has had the same argument for 4 decades, that doctors of optometry do not have the education or training. Our steadfast care in our communities is telling a different story. And the fact that no scope has ever been reversed in Virginia shows that our ask is always within the scope of care of our education and our training. And this is that time. I'm now going to introduce to you the president of the Virginia Optometric Association, who will make some remarks.
Can I ask one question real quick?
Yes.
So I had understood in this voluminous packet of materials that I've accumulated over the last few days that the Veterans Administration did not allow optometrists to.
There was a
But you said
period.
they did, right?
There was a period of time that they did. There was a period of time that they took it away, and now we're in a time where optometrists are being paid to do the procedures in private offices.
All right.
I'd like to give this to you, Mr. Chairman. This
Thank
is
you.
from a colleague of mine who could not be here today.
All right. Thank you.
Thank you for having me this morning. As Dr. Michael said, I'm Dr. Lisa Gontarek. I'm a doctor of optometry from Chesapeake. While Dr. Michael spoke more to what our opposition will say, I'd like to take a couple of minutes to talk about the effect that this bill will have both on patients and providers in Virginia. As it stands right now in Virginia, if a patient of mine requires one of these procedures, I have to refer them to an ophthalmologist. Even though I made the initial diagnosis, I've been treating often the condition already with other means, and I've been trained and certified to perform these procedures, I cannot provide these services for my patients. The patient must make another appointment, take more time off of work, or for my elderly patients, coordinate another ride. They have to have another exam before they can have treatment, and they will incur more out-of-pocket expense due to the prevalence of high-deductible insurance plans today. When I educate my patients about their need for one of these procedures, they often ask if I can perform that or if I can help them, and then I must explain why I cannot. With optometrists performing these procedures, patients receive continuity of care by a doctor that they already know and trust. They will not have to incur multiple co-pays for duplicate services. Patients will not have the stress of starting over with a new doctor. All of this makes for better patient compliance, more efficient healthcare delivery, and cost savings. I know 2 optometrists personally, one in Grundy, one in Norfolk, who were performing these procedures in other states prior to coming to Virginia. Once they got here, they were no longer permitted to do so. Imagine their frustration to have to stop providing the level of care that you were trained to perform and that you're actually providing elsewhere. The letter that I handed you is from a classmate of mine. She has a multi-location large practice in Southwest Virginia. She currently has a laser in one of her offices, and she actually employs an ophthalmologist to come in and use it to treat her patients. Because there's only one doctor there permitted to use this technology, they are currently scheduled out to April with patients who need these procedures. Optometry students today are looking to move to states that have a lot to offer. They look for a good cost of living, they're looking for a nice place to raise a family, have access to recreation and entertainment. But they're also looking to live somewhere that they can practice to the fullest extent of their training. Attracting these doctors to Virginia will help to ensure our growing and aging population will continue to receive the top-notch care that they need. Optometrists have the resources, education, and training to provide excellent care. We are a compassionate profession whose patients seek us out more than any other eye care professional. As doctors of optometry, we take an oath to keep the health of our patients as our first consideration. We pledge to practice optometry conscientiously and to the fullest extent of our competence. We pledge to place the treatment of our patients above personal gain. The vision and welfare of Virginia citizens depend on us. Help the people of Virginia to stay healthier and to see better. Please support Senate Bill 375. Thank you.
All right, thank you.
Sir.
Yes, quick question. Yeah.
And I know somebody's told me this on the 37 conversations I've had about this in the last 10 days.
What is the equipment cost for this?
It can range, I think, anywhere from about $35,000 up. That's the low end.
Okay. So, I mean, and the reason I asked that primarily is because, I mean, one of the more compelling arguments for this, the expansion, is the access issue. So, I mean, do you have a sense of how many, I guess you probably don't, how many optometrists would be able to avail themselves of this, given the equipment cost, the upfront cost? No sense.
That's a great question. We have probably about 1,500 optometrists across the state. I'm not sure what percentage of those doctors would be able to do that.
Yeah, you wouldn't know. Okay.
Thank you.
Yeah, thank you.
Save the worst for last.
There you go.
Mr. Chairman, Bruce Keeney, Senators, I'm here representing the Virginia Optometric Association. Let me first address the question, excluding all of the recent new graduates that have had all this certification and everything from their schools, we have run 2 classes in Virginia courses. We already have, as laser certified in Virginia, a little bit over 100 of the doctors even before this legislation has become enacted, to answer your question. Okay. I want to point out, most of you know this, anytime optometry seeks an expansion in their scope, we believe it is to assure that they have the best tools available to help the patients. Whether what was their ability to diagnose, to use diagnostic drugs, prescribe therapeutic drugs, injections to treat chalazion, and now the 3 lasers. As some of you have seen firsthand, each and every time ophthalmology has a history of coming in and using misinformation and attacks on optometry's education and training. They've even stated of an optometrist scope, expanding it, will result in blinding people and people dying in the streets. Some of you remember those comments before Senate committees. So here's some facts. To remind you, 1, this bill does not allow an optometrist to do cataract surgery, and not retinal surgery, not LASIK. But the American Academy of Ophthalmology has a little thing called Safety Coalition that's heavily engaged in social media and misinformation. Get this, I got an email from them asking me to write my senator to oppose this legislation because optometrists should not be allowed to use scalpels. That's the kind of information we've seen historically, and we're still seeing it. Back here in Richmond, many of you, and back home, Many of you probably had representatives from the medical society or the ophthalmologists say that only MDs are qualified to perform surgical procedures. Sometimes they'll say, if anybody wants to do surgery, they should go to med school. Well, I want to remind you that dentists who have very similar postgraduate training as optometrists are using lasers, including the YAG laser in this legislation. And podiatrists and nurse practitioners are doing surgery. When they attack optometry's education, they don't mention optometrists have been treating glaucoma in Virginia for over 30 years. They forget optometrists have completed their doctorate, which has over 10,000 hours of training in the eye and vision system. Most of them won't even refer to an optometrist as a doctor. They just won't. They forget that ophthalmic laser procedures are taught in every school of optometry. They forget, here's the important part for you, they forget to mention that optometrists have been managing post-op complications for years, including complications from the use of ophthalmologists using these lasers. Think what I just said. The optometrists have been treating complications when they do occur from a laser used by an ophthalmologist. So they're clearly trained and experienced in treating any complications into these procedures. They won't tell you that these don't involve scalpels, anesthesia, or sutures, and that it only takes a couple minutes to do these procedures. They won't tell you that the attachment of lasers or equipment now, as Dr. Gondek said. The sneer by medicine is nothing new, nor other for us or for other health professions. I personally, in my 47 years of doing this, have seen medicine oppose scope of practice for oral surgeons, podiatrists, chiropractors, physical therapists, clinical psychologists, pharmacists, podiatrists, nurses and nurse practitioners, and more. And it is the exactly same argument every time. Misinformation, they don't have an MD degree, go to med school. This bill deserves your support because optometrists are highly trained doctors who are educated on these procedures. There's a proven track record of no patient harm in states allowing them to use these procedures. It reduces cost to patients, and it increases needed competition in the delivery of health care. I do want to point out, most importantly, is that, if you think about it with the existing ophthalmologists, and they won't tell you this, one of the procedures, we use the initials for these to make it easier because I can't pronounce them either. You did a good job. PI, SLT, and YAG. Okay, that's easier for everybody to say. The SLT laser was approved by the FDA in 2001. That means that if the ophthalmologist in Virginia was licensed prior to that date and is now using that laser, they didn't have any additional training, no additional course, no clinical instruction, whatever. And in most cases, and it's just the way it is and it's worked, their training comes from when a new equipment comes in from the sales rep or a video or a conference. And it's worked. But my point being is optometry wants to do it the right way and does it the right way. Outside of their basic education or their doctorate degree, they want to make sure that you're going to take a course to supplement that base knowledge, that you're going to have to pass an examination and be certified in accordance with the state licensing board standards. That's a great standard that actually we would recommend for everybody in the future. I will also tell you, despite all the previous claims, as you've heard, diagnostic drugs, injections, all this other kind of stuff, zero complaints of patient harm from any of those in Virginia. Now, there's always the allegation of patient harm. When I'm finished, Bo will be handing out you the documentation on this. Alaska, since July 2017, quote, no complaints regarding care. Kentucky, since 2011, over 40,000 laser procedures performed, no complaints, not heard of any adverse complaints. Louisiana performed 14,311 laser procedures with zero negative outcomes, no complaints to the board, not aware of any malpractice suits filed. All of this is documented and you'll be provided it. Oklahoma, first 10 years, beginning in 1988, 5,000 procedures, no negative outcomes. After 1998, at least a minimum of 50,000 additional procedures with no complaints registered. Now, we're going to show you how straightforward we are. In Oklahoma, there's a case of an optometrist with 2 laser issues. and it's been used in other states that, oh, this is an example of harm. What they won't tell you is that laser was a different laser called PRK. One, it's not in this bill, and two, it's specifically prohibited for an optometrist to use PRK in Virginia. But they won't mention that. And last, oh, in Oklahoma, by the way, with 32 years of this, they have one of the lowest malpractice rates for optometrists in the nation. And the carriers will tell you that. So in short, patient harm in other states where they use these lasers is zero, none. And I've looked hard, I've researched, it's just not there. The optometrists in Virginia are seeking this not because of ego, not because it will reap great financial rewards. They're seeking this because they have a commitment to provide the best available quality care to their patients, and that means staying abreast of technology. They are trained specialists in their own right. They have a track record to prove it. For their patients, we ask your support. Thank you.
Thank you very much.
As he alluded to, here's the documentation from the various state licensing boards for members of the committee from the states where this is permitted with optometry. So if you would be so kind.
Sure. You used your 20 minutes now, so we will now proceed to those who are in opposition to this bill, and you will have 20 minutes as well.
Mr. Chairman, good morning. I'm Cal Whitehead. I represent Virginia. I'm just going to make a quick comment and let the surgeon speak.
Okay.
I'm with the Virginia Society of Eye Physicians and Surgeons. We oppose this bill, and want to point out that Virginia is among the 43 states that prohibit optometric surgery. It's a sound, long-standing policy. It is supported in several ways by Virginia statute, and we should not abandon that here. And I'm going to have Dr. Mike Keverline, who's an ophthalmologist and the president of our organization, walk you all through the procedures that are listed in Senator Peterson's bill, and hope you'll ask him some questions. And then we've got a few more folks to talk about different aspects of safety training, the population we're dealing with, and also access to care. So thank you for the opportunity.
All right.
Good morning, Chairman Barker and members of the subcommittee. Thank you very much for the opportunity to be here today to talk about these important patient safety issues. I'm Dr. Michael Keverline. I live in Norfolk, and I have my ophthalmology practice in the Portsmouth, Chesapeake area. I'm the president of the Virginia Society of Eye Physicians and Surgeons, and we oppose Senator Peterson's SB 375. I'd like to talk about the surgeries that we're referring to in this legislation. First of all, make no mistake and do not be misled. The laser surgeries in SB 375 are surgeries. They are surgeries according to medical and surgical definitions and according to long-standing, repeatedly confirmed Virginia laws that are consistent with the overwhelming majority of states in the country. The surgeries I will describe are on lines 120 to 123 in the bill. Please stop me if you have any questions as I walk through these. I'd first like to draw your attention to page 2 of the handout I've given you, which shows the positioning for any of the lasers that are surgeries that are done in this bill. The patient has their head against the forehead rest, and the surgeon with one hand holds the surgical lens on the patient's eye. With the other hand, the surgeon maneuvers, focuses, and fires the laser for each and every individual laser shot. This is in no way an automated process. The first two surgeries we're discussing use the YAG laser. This laser works by vaporizing tissue, in essence, creating microscopic explosions inside the eye. Like any explosion, the effects, both good and bad, occur within the blast radius of the explosion. In YAG capsulotomy, this is done for scar tissue that develops after cataract surgery. The surgical lens implant is placed inside of and held in place by the outer layer of the lens called the capsule. The capsule is like saran wrap or shrink wrap around this implant. That capsule can become cloudy, as you see in page 5, which necessitates the capsulotomy procedure. As seen in page 6, the laser is fired through the cornea, through the lens implant, and breaks open the cloudy capsule. Now, this part of the capsule is approximately 1/15 the thickness of a human hair, and it is adherent to the lens, which is 100 times as thick as the capsule. So, in effect, in our blast zone analogy, we are firing through a 100-layer thick roll of saran wrap, trying to break the innermost layer of that saran wrap without damaging any of the other layers. Complications of this surgery occur even when done properly. When done poorly, damage to the lens, such as seen on page 7, can occur, and overly aggressive laser capsulotomy can also result in dislocation and loss of the lens implant. YAG peripheral iridotomy is only performed when the anatomy of the eye is not normal, and the iris bows out close to the cornea, as you can see in page 9. The laser is fired with high energy through the cornea and must penetrate completely through the iris tissue to make a hole. The blast radius issues with this type of anatomy are very clear from the picture. The iris is also filled with blood vessels, so about 50% of these surgeries result in bleeding inside the eye, as you can see in page 10. The final surgery at issue uses a different technology called selective laser trabeculoplasty, or SLT. This laser is done through a gonioscopic view, which means looking through an angled mirror on the surface of the eye. The view, and therefore the treatment, are upside down and backwards. Page 11 shows you the schematic of that laser treatment, but page 12 shows you what the actual surgical view is when doing the procedure. The white arc and dome at the top of these pictures are the cornea. The colored part at the bottom is the iris. And there is a very thin strip of slightly pigmented tissue in between the white part and the colored part that is the focus of this laser. And every single pulse needs to be right on that line. Complications of this treatment include damage to the iris or to the cornea, as can be seen on page 13. I hope I've helped you understand the seriousness of these surgeries. You, your loved ones, and your constituents deserve to know what's involved in the surgical treatment of the eyes and vision. Thanks again. If there are no questions, I'm going to turn it over to Dr. Letman.
Senator Sasslaw.
One of the things that one of the things that you heard them say in their presentation was that there have been 100,000 of these performed with no malpractice suits filed or complaints against them. How do you respond to that?
Well, sir, I don't have that data in front of me. I don't know whether that data is correct or true. I can tell you that injury and damage can occur without there being a malpractice settlement or a malpractice lawsuit. There can be payments made without a malpractice court case happening. There are a lot of different ways things can go down, but I have no specific knowledge of those one way or the other.
One of the things, I mean, and I'm undecided right on this, but I've been here through diagnostic drops. I've been here through therapeutic drops, and in each case, the ophthalmologist, the Virginia Society of Ophthalmologists would come in and pretty much say that, you allow this, and this is the end of civilization. and that just hasn't happened. And the fact that 8 states allow it, and 40 some don't, is obviously a consideration. But,
I think it's safe to say that the world will. I'm sorry for interrupting.
In 1996, 49 states allowed elected school boards, and 1 state, Virginia, didn't. And, we now do. But go ahead.
Well, sir, I don't believe the world is going to end with any result of this legislation. That's not what this is about. This is about the safety and the best care for the patients of Virginia. And that hasn't happened with other things, but I can tell you from my own personal experience that I have seen many problems and damage and mistreated patients under the care of optometrists before they reached me. And That has happened any number of times. Those things don't result in lawsuits because I'm not going to encourage them to sue the optometrist. I think that the person taking care of them was doing the best they could, whether they were doing the right thing or not. And I have seen dozens and dozens and dozens of inappropriate laser surgical referrals come to me. These are patients who, if they were in the care of the optometrist, would have had that laser procedure done. And they were inappropriate because the pathology was not as was described. So those don't result in lawsuits, but they do affect the care of that patient. And that's what we're talking about.
All right. Any other questions? All right. Next.
Good morning, Chairman Barker and members of the subcommittee. My name is Peter Netland, Dr. Peter Netland. I'm the chairman of ophthalmology at UVA. Thank you for the opportunity to speak with you as an individual eye surgeon and glaucoma specialist. I'm urging you to reject Senate Bill 375. So I have over 30 years of experience performing eye surgery and training. I train residents and fellows to become competent practitioners. I can tell you firsthand that, vision and health problems are common, but they're oftentimes fairly complex. Providing safe care to patients requires rigorous instruction and, more important, years of supervised training, which includes observation of trainees doing procedures. Lasers are a powerful and invasive tool. They're just a tool for doing the surgery. Lasers do cut and burn, and as you heard, explode and so forth in the eye, and they do cut through human tissue, much like a scalpel. And whatever is done with a laser can't be undone. It's a permanent change. So the major difference between an ophthalmologist and optometrist is the additional education and training and supervision of procedures and so forth. We do have the additional 20,000 hours of medical and surgical training, which occur during medical school and residency, and oftentimes fellowship, which is additional training as well. Optometrists do not have this. So the president of the Optometric Association was quoted at one point as saying, one important thing to know about optometrists is that they are different from ophthalmologists who are eye surgeons. Ophthalmologists can surgically address advanced glaucoma, cataracts, and retinal detachments. Implication is that optometrists can't. Optometrists are primary eye care providers, but they are not surgeons. Virginia is one of the majority of states that prohibit optometric laser surgery, and this reflects the recognition that the potential risks associated with invasive surgery, including blindness, as we heard earlier, require ophthalmology training. There really is no educational, scientific, or needs-based reason to change this common sense patient quality care and safety standard. So for these reasons, I respectfully urge you to vote no on this legislation. Thank you for the opportunity to speak.
Yes, Senator Lewis.
Just to follow up on Senator Sassel's question just a few minutes ago, how do you, I know it's only 43 states disallow it, but how do you account for these thousands of procedures that these other states say have been performed since beginning in Oklahoma in '98? I mean, what's your take on that?
Right. Yeah, I don't know the counts of the procedures. It's a relatively small proportion of the procedures performed in the United States. For example, one of the ones that they're requesting has been performed about 60,000 times last year. And so the number is large overall. So I don't know what percentage it is. We heard earlier that maybe less than 10% of optometrists may implement this or are certified at this time to do this. So I think it's the numbers sound big, but I don't know if it's it's a very big proportion of the total number done. So it's a small number of states that allow this.
Right, okay.
All right. Any further questions? All right. Next.
Good morning, Chairman and members of the subcommittee. I'm Dr. Nicholas Ramey. I'm from Roanoke. I'm an oculoplastic surgeon at Vistar Eye Center, and we have offices and surgery centers in 26 locations throughout Southwest in Southside, Virginia. Thanks for allowing me to speak in opposition to this bill. So everyone in the room agrees that all Virginians deserve access to high-quality eye care regardless of where they live. And I'm very fortunate to be part of an organization that has an unwavering commitment to recruiting top-notch surgeons and physicians to our region. Together with Doctors of Optometry, we've created a very robust community where patients have excellent access, whether measured by time or distance, to the best surgical and medical eye care in the country. And most recently, we've built centers serving Martinsville and Wytheville. So we're very proud of the quality of our region's network of optometrists, ophthalmologists, ambulatory surgery centers, and the multidisciplinary teams that we make up. But I want to reemphasize the importance of quality. As an ophthalmologist, I received years of hands-on, one-on-one supervised training to perform these laser surgeries. But when I meet a patient who needs one of these treatments, I refer them to a specialist. And that's because the specialist has the experience and the proficiency that only comes with volume, performing literally thousands of these lasers on real, live, human eyes that would otherwise have threatened vision. So we ask you to reject any notion that by lowering the quality of the professional standards of care, you can improve access to that care. It just isn't true. And I have no evidence that there's a lack of access to this care in Virginia.
All right, thank you.
Thank you.
Good morning, Mr. Chair and members of the committee. My name is Dr. Suzanne Everhart, and I'm a practicing ophthalmologist in Hanover, in the town of Ashland. And I've had the pleasure of practicing there for the past 28 years. I see patients from a very wide geographic region, and it's mostly a rural setting. Approximately 70% of the patients that I care for are Medicare and Medicaid. This population is elderly and very disadvantaged. This legislation that we're considering basically is turning a blind eye to the safety of our most vulnerable patient population.
I'm having a hard time understanding what you're saying. Can you?
I'm sorry, with the mask, it's hard.
Can you
I'll speak
move
up.
the mic closer?
Sure. The population that I care for is elderly, and they are disadvantaged. This legislation is turning a blind eye to the safety of our most vulnerable patient population. The majority of patients who undergo surgeries outlined in this bill are seniors. Seniors have complicated comorbidities such as AFib. They have to be on blood thinners. These surgeries done with laser are intraocular surgeries. It is very important that any type of surgery performed on patients, especially these high-risk patients, be performed by a qualified surgeon who can foresee the complications, recognize them when they occur, and have the surgical skill set to treat them, oftentimes urgently. I've been caring for many of my patients for over 28 years and have had the privilege of getting to know them and their families. They are passionately opposed to this legislation. In fact, one of them, Mrs. Nancy Kraus, is here today, and I appreciate her coming. I never take any surgical procedure lightly, whether it's done with a laser or a scalpel. Why? Because as every surgeon knows, there is no such thing as simple surgery. Every surgical procedure can become a major complication. This legislation puts the eyesight of the most vulnerable patients in the hands of the least qualified. It is for these critical reasons that I ask you to vote no on this bill. Does anyone have any questions for me? I very much appreciate the
Thank you.
opportunity to be here today. Thank you.
Mr. Chairman, Cal Whitehead again, that's the extent of our testimony, and happy to answer any more questions about our opposition.
All right. All right, are there any questions that any member of the committee has to people on either side of this issue? All right. Are there comments or discussion or a motion that anyone would wish to make as it relates to this particular bill, 375?
I've got a motion.
All right.
And I think we need an umpire here. So, I mean, and I'd like to speak to the motion after I make it. My motion would be that we recommend a chairman's letter to the Board of Health Professions to take a look at this, carry the bill over, take a look at this, and report back to us for next session.
Second.
All right.
And can I just speak to that for a second?
Yes, you can. There's been a
I mean,
second.
and I've got some notes that I wrote down last night going through this stuff. So,
What do you think?
I first, and you explained to these folks who have obviously traveled here about how we operate here. So I first learned of this coming storm, I don't know, a couple months before the General Assembly in my optometrist chair. And then, of course, it got fleshed out as we were here for a long period of time. You know, it's like on the one hand, on the other hand, with each of these points. And we're just not in a position in this truncated period of time that we have here to make a judgment like that. So you've got 42 states that allow it, but 8 who don't. But in the 8 who don't, there's, well, I'm sorry, yeah, other way around. But in the 8 who allow it, there's apparently a clean record. You got retreatment rates, but the retreatment rates are based on a faulty study, so the optometrist said. It's surgery. It's called surgery in the bill. But yet I recognize the institutional resistance that doctors have, just like lawyers do, when people start intruding on their area of practice. I got 2 letters in here from the American Glaucoma Society, chairman of ophthalmology at EVMS, and now we had the UVA chair here today. And then for people like me, where I live, it's an access issue. You look at the cost of the equipment, how many people are going to be able to have the equipment to access the procedure. So that's why I just think it is much too complicated for us to try and make this decision here today. And we, as I said at the outset, we need an umpire, somebody to give us some guidance on what the right thing to do is. When you're talking about medicine, you're talking about surgery, you're talking about people's eyes. I'm not comfortable doing that. So.
All right. Are there other comments? Yes, Senator Newman.
I don't know that, individual thoughts matter. I tell you, this has been a tough one. I think many on this committee probably been truth seekers the whole way, and that's the way legislation should be. We should be truth seekers. I think Cal's done a great job, and the other guys too, but here's where it just has come down to me is that I just keep asking for the outcomes. And I just can't get, Saslow, to your question, I can't get the negative outcomes. And if there were, or if there is, right? If it comes in an hour after we meet here, right? I'll switch like that, and I've told everyone that. I'm just, as a truth seeker here, it just seems to me that if we've got this many cases and there's been literally no outcomes, that's going to put me in a yes position today. But I got to tell you, if we end up with these outcomes that say this is a negative thing and we're harming patients, I can switch like that, and I imagine that a lot on the committee will too. So I don't know if it's any help at all. It's just kind of where I landed, sir.
All right. Yes, Dr. Brown.
I'm David Brown. I'm the Director of the Department of Health Professions. I just wanted to suggest if you move forward with this motion that you request it be a department study, because currently the Executive Director of the Board of Health Professions also serves as the Executive Director of the Board of Optometry, and I think it might be a little cleaner just to refer it to the department.
Okay.
Mr. Chairman.
Yes.
Just as a follow-up, based on the volume of the change in the code of this alone, including surgery, which is new, I ponder again, as we have this discussion so often, Why do we have entire boards of subject matter experts of legislators who are not familiar with the, with this situation are going to make decisions based on one or two variables? It's more complicated than that. It deserves to be vetted by subject matter experts. As a surgeon, I'm not one. And so I hope that this committee will see fit to have the subject matter experts in Virginia look at this. This is politics pulling us to make a decision in favor of one or another, as opposed to giving it the harsh light of truth and vetting that we see when it goes through a review of its peers.
Mr. Chair, what is the
Yes.
makeup of DHP? Who's on that? What's the makeup of that?
Dr. Brown, you want to answer that question? Because there may be secondary questions on that, because there are a lot of different boards that operate.
So what would be the makeup of the board that would be
So if
evaluating
we,
this?
If we referred it to the Board of Health Professions, which is one, we have 13 health regulatory boards, and we have an umbrella board, and that board is composed of one member from each of the licensing boards: optometry, medicine, physical therapy, et cetera. And I think either 4 or 5 public members, citizen members. So that's the makeup of the board. Sometimes studies are simply referred to the department, and then we have someone who, myself, our chief deputy, our policy person, convene a group and do that. So we could do it either way.
Right. Because as you mentioned optometry. I think there's a concern that if this is evaluated by a board that's all physicians or all optometrists, it's going to give an unfair advantage to one or the other.
I think either way, it would be experts from both sides would be considered.
Mr. Chairman.
The only thing I was pointing out is that just from, and I don't have a concern about this, but for appearances, the executive director of the Board of Optometry also serves as the executive director of the Board of Health Professions.
Mr. Chairman, just to follow up, having served on these boards, if you convene an ad hoc committee, can be a balanced and vetted process. Whether or not the Department of Health Professions votes for that, you can have the committee work, which is one of the things we're looking at with pharmacists this year. And so, I think we all have the ability to filter that information, but, this major change in scope in surgery deserves vetting.
All right, are there any other comments or questions? Senator Peterson, do you want to add anything to the discussion?
I'm reminded of the quote, "The fierce urgency of now," and I'm not stupid. If this gets pushed off to a commission, it's a way of defeating the bill. And so I recognize where the sort of trend is going. I'd just as soon have an up or down vote. It's not going to break my heart, but y'all do what you do. I appreciate the time. And listen, I'm not making light of any of the commentary. It's a tough issue, and I've people I respect, again, back home I spoke with. To me, I think this was a very limited, discrete request. So,
Mr. Chair, I do have one other question.
Yes, Senator
For the
Kelly.
optometrist.
Yeah.
So, any optometrist that wants to come forward and answer this, that'd be fine. But hearing from both groups, I keep hearing about FEMA, I guess is what it is, that the eyes fill with blood and it's got to be treated immediately. And if an optometrist does that procedure, they wouldn't be capable of handling that. Can you answer that question for me? That's the only thing that I'm having trouble with from the optometrist.
I'm Dr. Jerry Natty. I'm currently the Virginia Optometric Association Legislative Chair. As was mentioned, we're trained to handle any of the complications from this procedure. As far as a hyphema goes, As far as a hyphema is concerned and blood filling the eye, it simply requires pressure. Pressure from the lens that we're trained to place on the eye as part of our training in optometry school.
So that's something you could handle. It's
Yes.
not you can get one.
Yeah.
Well, yeah, I'll just add to that commentary that, yeah, thank you. Yeah, I'll just add to the commentary that sometimes it's an increasingly small percentage to get more and more serious issues. Of course, hyphemas can resolve. They can be slowed down by pressing on the eye. They can improve. over time by letting the blood resorb and so on and so forth. But there's always that small percent that will go on to other issues. We have anterior washouts, which is a surgical procedure, which does occur in a certain percentage, again, a smaller percentage, and then other issues that can occur from that as well. Glaucoma and various other things that can be the result of that. Again, increasingly small percentages, but then it does lead to problems. So, and who that affects is kind of random. There are risk factors, but when they occur, sometimes arbitrarily, it seems almost, somebody has to be able to manage it further, or else it can lead to serious problems. So, I mean, it's a percentage thing, and yes, a small percentage will go on to develop more serious things that do require surgical treatments and additional interventions.
All right, thank you. All right, are there any other comments or questions? All right, the motion that is before us is move to report. All right, we have a motion to and a second to report. Is there a discussion on that? All right, would the clerk call the roll?
Senator Saslaw,
Aye.
Senator Newman, Senator Edwards,
Senator Edwards votes no.
Senator Lewis,
No.
Senator Donovan,
No.
Senator Suderline,
Yes.
Senator Pillion,
Yes.
Senator Barker.
Yes.
Ayes 5, noes 3.
All right, now, so this is a recommendation of the subcommittee. I mean, we're obviously not the final group that will be dealing with this. This will go to the full Education and Health Committee next week.
Will there be a hearing on it, Mr. Chair?
No, what Senator Lucas has said is if a bill is heard in subcommittee, that at the full committee, there's not further testimony provided at that point. There may be questions that could be asked of both sides, but there's not a testimony provided.
Okay, great. Thank you.
All right, thank you very much. So,
You know, I've been here, you know, they come in so many times predicting the end of the world.
I know, that's the thing that drives me nuts.
Yeah.
yes.
We are adjourned.